Welcome to the BHRT World Summit. The purpose of the summit is to reach as many people as possible with the approach of using bioidentical hormones when it is appropriate, so the public will understand it and seek physicians to help them if they have a need to regain their health or to maintain their health. Bioidentical hormones have been used by thousands of licensed doctors who understand how the body works, can medically determine what may be missing, and be ready to replenish the body with exactly what it needs, instead of prescribing the newest chemicals on the block. We now have the wonderful chance to speak to Rebecca Glaser, MD. Dr. Glaser retired from breast cancer surgery in 2004 and is currently involved with balanced hormone therapy and its impact on health care. She has evaluated and treated over 2,000 breast cancer patients and over 1,500 patients with hormone imbalances. She continues to treat patients and train physicians worldwide. She lectures on evidence-based hormone balance in health, hormone balance in breast cancer prevention, hormone therapy with pellet implants, and vaginal delivery of hormone therapy. She established the website www.hormonebalance.org as a nonprofit educational website for patients and for healthcare providers in 2005. The website has over 1,600 full-text peer-reviewed articles supporting the use of balanced hormone therapy. For anybody who thinks that bioidentical hormones is not something that has medical research, they should be advised to see her website. Dr. Glaser is working on several research projects. She is also collaborating with the National Institute of Health on a manuscript dealing with hormone levels in newly diagnosed breast cancer patients. We are truly fortunate to have Dr. Glaser here with us today. It's now my pleasure to begin talking with Dr. Glaser. Welcome.
Thank you.
Can you tell me about your website that you've developed? It's really fascinating. I haven't seen anything like it. It's a big help to doctors and to patients.
Thank you. The website is www.hormonebalance.org. And probably the most important part of the website to me, and the thing that I'm most proud of, is the data section. When I practice hormone therapy, I want to practice what we call evidence-based hormone therapy. So it's really important to me that I have data to support what I do. And in the data section of my website, there are over 1,600 full-text articles which support balanced hormone therapy. Now, because they're articles out of the library, you need a username and a password to access the data section. And the username is data, D-A-T-A, and the password is data, D-A-T-A. So I think knowledge should be available to everyone.
That's really wonderful, and I hope that people take advantage in looking at your website, which we'll have a link on our website also. One of the wonderful things about it is that you seem to be an advisory clearinghouse for how to get more information. Articles that you personally didn't write, but articles that you stand behind and feel that it makes a lot of sense, and medically it's what you see in your practice. People can access those things to get more details, and they can look at it in the way that they would like to, and glean a lot more than they would from a doctor's office visit, which sometimes he doesn't have or she doesn't have an hour or two to go over these details. So you really are doing a wonderful service for people that they could access those things.
Thank you. And also, all the information on the website can be passed on, it can be copied and shared. There's nothing copyright protected on there, so everything is for use for everybody.
We're not used to things like that, so thank you. Now that we know what kind of person you are, putting these things out there, getting them all together, not making it copyrighted, tell us, how did somebody like you, who was trained in surgery, which is not an easy thing, who dealt with the emotions of people that are hoping for their lives and fearing for the worst, how did you make the switch out of being a surgeon for breast cancer to giving hormone therapy?
Well, I think it was the fact that I realized health prevents disease. And looking at my breast cancer patients, I realized that deep in my heart, I felt that breast cancer is a preventable disease. Part of that is hormones. Hormones in balance are absolutely critical to health and disease prevention. I feel very strongly, and hopefully by the end of this talk you'll understand, that I feel that hormones in balance actually protect against breast cancer. Hormones out of balance, including bioidentical estradiol, may contribute to an increased risk of breast cancer. The other thing we know is the synthetic chemical hormones, and I hate to actually even call them hormones, but the synthetic chemical hormone substitutes like Premarin and Provera and Estratest and methyltestosterone have clearly been shown to increase the risk of breast cancer. But it's not just about hormones. It's about diet and lifestyle. You have to have a diet that's healthy and a lifestyle that's healthy to have hormone balance and overall health. The other component is stress. Stress wreaks havoc on hormone balance. And one of the underlying things I saw in my young patients with breast cancer was the amount of stress in their life, the amount of turmoil. And I know in my heart that that contributed to breast cancer.
I think of the hormone system as the most fragile of our systems. When there's stress, whether it's from food or sleep or emotions, it's the hormones that are the first thing that get out of balance.
Oh, I agree with that. The focus of my talk is hormone balance because that's what protects people and prevents disease.
Can you tell us what are bioidentical hormones?
Well, bioidentical hormones are actually hormones that are identical in composition to human hormones. They're chemically converted from yams or soy. The problem with them is you cannot patent a bioidentical hormone. So it's a natural substance. So pharmaceutical companies are less likely to want to invest a lot of money in a hormone that they can't patent and can't make a lot of money off of. Now, some bioidentical hormones are able to be patented because of a delivery method, like the patch, like the estradiol patch and the testosterone patch. So pharmaceutical companies have been willing to invest money in patches. The bioidentical hormones have been used in Europe and the United States for over 60 years, and they have been extensively researched. One of the things you need to understand is estradiol, progesterone, and testosterone are actually FDA approved. And what this means is a pharmaceutical company has taken them to the FDA and asked for approval. Now, one of the criticisms of bioidentical hormone therapy is the fact that they're not FDA approved. And a lot of people don't understand what FDA approval means in the United States. Or what FDA approval is indicated for is if a pharmaceutical company wants to market a drug to the public, they have to get FDA approval. So FDA approval in the United States is required only if someone wants to market a drug or a chemical to the public. The other thing about bioidentical hormones is that in balance, again I said in balance, they do not have the same risk as conventional hormone replacement therapy. And this is particularly true of the synthetic progestins and the synthetic testosterone.
Well, what's the difference between the bioidentical ones, progesterone or progestin?
Okay, the difference is they're totally different chemical structures. Mm-hmm. And they fit into what is called a receptor. Now, what a receptor is a little area on a cell membrane where the actual hormone fits into and creates its effect. When progesterone fits into that receptor and a synthetic chemical progestin, they actually have a different effect on the cell. And also, they can also affect other receptors differently. Like one of the ways the synthetic progestin has been found to increase the risk of breast cancer is it actually fits into the testosterone receptor or androgen receptor and prevents the beneficial effect of testosterone on that breast cell. There are, in conventional hormone replacement therapy, a lot of hormones that are identical to the body. For example, prometrium is oral progesterone. We also have vaginal progesterone products. There are oral estradiol products. There are topical estradiol products, including an estrogen gel that's applied to the skin. The estradiol patch is bioidentical. For men, we have the androgel, which is bioidentical testosterone, and androderm, which is a patch that delivers testosterone. Also available in Europe is estriol, which is the estrogen that has not been FDA approved in the United States. Ovestin, which is vaginal estriol cream, is actually sold over the counter in Europe. That's how safe it is. They also have an oral estriol product available not only in Europe but also Japan.
Don't we have Ovestin in the United States?
We don't have Ovestin in the United States.
It's the same bioidentical hormone as estradiol or progesterone. I wonder why we don't have it in the United States.
I think probably because it's been around for 60 years and it's not patentable, and I don't think there's a pharmaceutical company willing to invest a lot of money on studies in the United States when another company could come along with a generic product.
One part of the word of bioidentical hormones I think is confusing to a lot of people. It's bioidentical natural hormones. The chemical hormones could actually also come from Mexican wild yams and soy too. But when they leave the laboratory, they definitely look a lot different than our hormones. But that word natural makes the conventional doctors that want to have an argument against us say yours are no more natural than ours because they all come from the laboratory.
That's correct. And I don't use the word natural hormones because I think it's vague and it's confusing. Natural, some people consider natural Premarin from horse urine because it's a natural product. So I don't use the word natural when I'm talking about hormones. So I use the word identical to human hormones, and I do use the term bioidentical sometimes. But I think you're correct. I think the word natural can be very misleading.
Bioidentical hormones are maybe coming from Mexican wild yams or soy, but they stop over in the laboratory to get a little reaction of the chemicals so that when they leave the laboratory, they are exactly the same hormones that our body makes.
That's correct. And they fit into that hormone receptor exactly the same as the hormone made in the body.
The point that you made there also explains something that I see in my practice all the time. Menopausal women that are on HRT, and they decide for one reason or the other, the doctors feel, oh, you've been on it long enough, thank God you haven't gotten cancer, but we can't continue it. Or the ladies are scared themselves because the more they read, the more they understand that it's not for them. When they get off of their hormone replacement therapy, it seems so hard for them to be able to reach a balance afterwards because their HRT was affecting so many different kinds of receptors.
I think that's very true. I think stopping hormone therapy, especially the strong conventional hormone therapy, can be very difficult. Part of the thing is people do not understand the difference between synthetic hormones, out-of-balance hormones, and imbalanced bioidentical hormones. They lump all hormones together and think that all hormones increase the risk of breast cancer. We know from the Women's Health Initiative trial, which was a large study done in the United States, that it was the combination of the synthetic progestin, Provera, that increased the risk of stroke, heart attacks, and breast cancer. It was the synthetic progestin that caused the blood clots and also was felt to be a contributor to Alzheimer's disease. Estrogen, for the most part, is brain protective. And estrogen, not taken orally, does not increase the risk of blood clots. So the increased risk of blood clots and stroke is a combination of being a synthetic hormone, but also a hormone taken orally. Now, this was no surprise. We knew that the synthetic chemical progestins increase the risk of breast cancer. There were a huge number of studies already in the literature that confirmed this. We know that it's the synthetic chemical progestins that increase the risk of heart disease. So this was not a surprise from the Women's Health Initiative trial. The synthetic progestins actually act as something called a coronary vasoconstrictor, which means they narrow the blood vessels that give oxygen to the heart muscle. Estrogen is protective to the heart muscle and blood vessels. So this was not anything we didn't know. But what happens is when you add the synthetic progestin to it, it cancels out that protective effect. The synthetic progestins over and over have been shown to increase the risk of blood clots. We're not just talking about blood clots in the legs. we're talking about pulmonary embolism, or massive blood clots in the lungs, and also strokes. So the synthetic progestins, which are given as part of hormone replacement therapy to women that have a uterus, increase the risk of strokes. The oral contraceptive pills have been clearly shown to increase the risk of blood clots and strokes. Besides that, the synthetic progestins have a negative effect on mood and mental status, and they can increase the risk of Alzheimer's disease. The synthetic progestins actually cause birth defects, whereas progesterone is actually needed to maintain a pregnancy. So there's a big difference between the synthetic chemicals and the actual hormone progesterone. Progesterone clearly does not increase the risk of breast cancer. It also doesn't have toxic effects or negative effects on the vascular system, which means it doesn't cancel out the beneficial effect of estrogen on blood vessels. In fact, progesterone, the hormone found in the body, acts as a coronary vasodilator, which means it opens up the blood vessels that give oxygen to the heart muscle. We know that the synthetic progestins increase the risk of dementia or memory loss. Progesterone itself is brain protective. So there's a big difference between the synthetic chemical hormones and the actual hormone that's found in the body. The problem is physicians don't even understand that they're different, and they lump all hormones in the same category.
You're 100% on target. I have so many patients that come to me and they say, you can't take progesterone or any hormones. Why do they say that? Because their superficial reading of the Women's Health Initiative said that the word progestin, and that sounds like progesterone, which means that the whole thing is not good. And I have also people that come to me that have blood clots, history in their family, or maybe even some clotting problems, and they come with a big note from their doctor, never is allowed to take hormones, and the patient, of course, is suffering from hormone imbalance that you could cry over. And would this type of person be allowed to take progesterone?
Well, what it is I never give just progesterone. The whole key to what I do is hormone balance. And yes, I would treat that patient with hormones. But what I would do is I would not give her hormones by mouth. I would not give her oral hormones because oral hormones increase the risk of blood clots. Now, there is a study that showed that oral progesterone did not increase the risk of blood clots, but I would still avoid the oral route because that's a single study, okay? There are other ways to give hormones, and one of my favorite ways to deliver estrogen and progesterone is by the vaginal route. And we'll talk about that a little bit later. But vaginal hormone delivery does not increase the risk of blood clots. It does not increase clotting factors. So it is a very safe way to give hormones. Also, hormones, in particular testosterone, delivered by a pellet implant, which is basically placed under the subcutaneous tissue under the skin, does not change the clotting factors, does not increase the risk of blood clots. So yes, I think a patient with a history of blood clot or a family history of blood clots or a deficiency that increases clotting in our bloodstream is certainly a candidate for hormones, bioidentical hormones, not delivered by mouth. Because again, it's when the hormones go through the liver or affect the liver that you increase the clotting factors.
How can physicians and the organizations say that the risks and benefits of all estrogens and all progesterones are equivalent?
You know, I hear that all the time. Local gynecologists, the North American Menopause Society, the American College of Obstetrics and Gynecology claim that there's no difference. And I think part of the information they obtain that from is a large trial out of England called the Million Women Study. And what this was is it looked at over 1 million women, which is a huge number. And they looked at the incidence of breast cancer with hormone replacement therapy. And what they found was there was no difference between estrogen formulations. Estrogen alone increased the risk of breast cancer slightly. And it didn't matter if it was oral estrogen, oral Premarin, topical estradiol, it all increased the risk of breast cancer slightly. But what a lot of physicians don't understand was vaginal estrogen therapy, in particular estriol, wasn't included in estrogen formulation. With vaginal estrogen, or estriol, the relative risk of breast cancer was actually lower than no hormone replacement therapy. So it did not increase the risk of breast cancer. The other point from the Million Women study was there was no difference between progestogen formulation. But what a lot of physicians and organizations don't understand, unless you read that article carefully, is progesterone wasn't even used in the study. Mm-hmm. So they're true. The synthetic progestins almost doubled the risk of breast cancer, but progesterone wasn't used in the study. Now, there's a beautiful study out of France called the French Prospective Cohort Study, and they have results on over 80,000 women. And again, they found that there was no difference between estrogen formulation. There was no difference between oral estrogen or percutaneous, which means estrogen applied to the skin. They all increased the risk of breast cancer slightly. However, in Fournier's study, they compared progesterone to the synthetic progestins. That was one of the main endpoints of the study. And progesterone clearly did not increase the risk of breast cancer, and the synthetic progestins increased the risk. The other thing found in Fournier's study, which is exactly what was found in the Million Women study, is that vaginal estriol therapy did not increase the risk of breast cancer. And we've known that. There were several other studies in Europe on vaginal estriol that included vaginal estriol as an arm of the study, and that clearly did not increase the risk of breast cancer. There's even a study in women with a history of breast cancer that were treated with vaginal estriol therapy, and they actually were found to have a lower risk of recurrent cancer. So when they claim all estrogens are the same, that's not true. It is true that there was no difference between oral estrogen and topical estrogens applied to the skin. There was no difference between Premarin and bioidentical estradiol. However, vaginal estriol was never shown to increase the risk of breast cancer.
Where does estriol fit in the normal physiology? When is it most prominent in a woman's life?
One of the times you see a lot of estriol in a woman when she's pregnant. So pregnant women have really high levels of estriol. So a developing fetus is actually bathed in estriol for 9 months.
That must have an important reason, and the woman is in a healthy way while she's pregnant, not only for herself but for her baby. So estriol doesn't sound like that it's a dangerous thing to have.
Right. And it's one of the hormones that I use a lot in my practice. But remember, a lot of my patients are from my breast practice, and I am so in tune with what is the safest way to deliver hormones. And I feel that the vaginal route, and I deliver estriol, sometimes estradiol, and progesterone vaginally, all in the same cream. Vaginal estriol has clearly been shown to be absorbed and relieve menopausal symptoms. The reasons I use estriol is that it has a high binding affinity, which means that it has a good effect on the vaginal tissue and also the bladder tissue. But it has a very low binding affinity for the breast tissue. And vaginal estriol has been shown not to stimulate breast tissue. Not only does it not increase breast density, but clearly it does not increase the risk of breast cancer. Vaginal estriol, and the reason it's used in Europe is you don't have to give progestins with it, does not stimulate the uterine lining if it's used in the correct doses. So that's really important because we know it's the synthetic progestins that increase the risk of breast cancer. Also, it protects the blood vessels. It's vasoprotective. So I really like the hormone estriol, and I like it delivered vaginally.
Are you saying that when you use estriol vaginally, you don't have to use progesterone?
Correct. You don't have to use progesterone. If you use, and that's why they use it in Europe, because Europe is so far ahead of the U.S. as far as recognizing side effects of progestins, doing studies on progestins. So one of the reasons that they use estriol is the fact that you do not have to give a progestin with it to protect the uterine lining. If you give estriol incorrectly, though, if you give it 2 or 3 times a day in high doses, it can stimulate the uterine lining. But if you give estriol correctly, it does not stimulate the uterine lining, and it does not increase the risk of uterine cancer or breast cancer. Practice, I give vaginal progesterone with the estriol.
Do you find that women that come in that can't sleep through the night because they have to urinate through the night once or twice or 3 times, that that symptom goes away when you treat them with vaginal hormones?
Mm-hmm. Yeah, that's a great question. 87% of the women that come to see me have vaginal and urinary symptoms, meaning they have the vaginal dryness, the urgency, feeling like they have to urinate and they don't have a full bladder, urinary tract infections, getting up in the middle of the night to urinate, and probably 95% of those people get better with vaginal hormone therapy. So, yeah, it's very effective for the urinary and vaginal symptoms.
Sounds like the urologist ought to be learning about it.
Mm-hmm. I think one of the things that disappoints the urologist is the incontinence studies with estrogen. But if they would look at estriol, there is data to support that it helps with incontinence. But the thing I found that actually reverses incontinence the best is the testosterone pellet implant. And we're going to actually be looking at that in a study.
Do you use this vaginal estriol I guess you use it as a cream or a suppository?
No, in my practice, I actually use it as a cream. And we just recently got a study accepted for publication on the vaginal administration of hormones, efficacy and safety. And again, what I do is I combine hormones into a single cream. Now, normally when I treat female patients with hormone therapy, I use the testosterone pellet or implant. And we'll talk about that in just a minute. And what I do is I put the estrogens, usually estriol, and a small dose of estradiol along with progesterone in a single vaginal cream. But what we do is we concentrate the cream because no one wants to use a whole gram or cc of cream. That's messy. But if you put it in a tiny amount of cream, a pea-sized drop, it is not messy at all. It is very effective, and women are very compliant.
What about synthetic testosterone versus testosterone, the hormone?
Well, once again, methyltestosterone is not testosterone. One is a chemical, and the other is the hormone found in the body. But you know what? Even physicians don't understand the difference. There was an article recently in the Archives of Internal Medicine, and the title of the article was Combined Estrogen and Testosterone Use and the Risk of Breast Cancer in Postmenopausal Females. But they didn't use testosterone in the study. They didn't use estradiol or bioidentical estrogen in the study. What they used was oral synthetic methyltestosterone. It was the oral synthetic methyltestosterone that increased the risk of breast cancer in the formation, for the most part, of estrotest that has a synthetic estrogen and a synthetic testosterone. But even in a medical journal, they did not differentiate between the synthetic chemical and the hormone. We know that non-oral testosterone, the hormone, prevents the stimulation of breast tissue and lowers the risk of breast cancer. So it's very different acting than oral synthetic methyltestosterone. We know that testosterone is anti-proliferative, which means that it prevents the proliferation or growth of breast tissue. It also prevents the growth of breast cancers. Testosterone itself increases breast cancer cell death. So it does not act like the methyltestosterone, or I should say methyltestosterone does not act like testosterone.
I'd like to ask you, a woman has a lot of testosterone. At what age, and when does she start to lose it, and why does she start to lose it?
Probably a healthy 20-year-old woman has a very high testosterone level, and that's when she's her most productive, her most vibrant, her physical peak of her health. We know that by 40 years of age, a woman has half the testosterone that she had at 20, and I think that's part of the aging process. But I also think we're seeing lower and lower testosterone levels not only in women, but in men, at least in the United States.
Are there any studies that show the effect of testosterone in breast tissue?
Yeah, there's some really good studies, and one of them is by an author by the name of Jin Zhu that showed that testosterone inhibits the growth of breast tissue. And what they did is they looked at rhesus monkeys, which have primate breast tissue, which is very similar to ours, and they showed that estrogen alone increased the growth of breast tissue. There was no doubt about it. And it also increased something called estrogen receptor alpha. This is important because that's a receptor that breast cancer cells need to grow. They also showed, which is very important in the study, they also showed that testosterone prevented the estrogen-induced proliferation. So it prevented the growth of breast tissue from estrogen and totally eliminated the growth of estrogen receptor alpha. So that is absolutely a phenomenal study. They went on and re-looked at the data, and again, they showed that if you blocked that receptor, the androgen receptor, where testosterone normally fits into, the breast tissue increased. It proliferated. It grew. They also again showed that if you gave a testosterone pellet and gave those rhesus monkeys estrogen and progestin therapy, that the testosterone was able to prevent the growth of breast tissue. And again, it lowered that estrogen receptor alpha. Now, this study showed no change with progesterone. It was not a negative effect, but it was not a positive effect. An even more important study is a study that was done in humans, and it's out of Australia, where they took postmenopausal females who were referred for testosterone supplementation. And the indications for testosterone supplementations are the same indications we use: emotional lability or instability, fatigue, depression, memory loss, loss of concentration, breast tenderness. So that was an indication for testosterone therapy. It was actually breast tenderness in this study. Loss of libido and sleep disturbances. Women were also referred for muscle loss and weakness. And what they did was they gave these women who were on conventional therapy, they gave them a testosterone implant or treated them with a testosterone implant. A number of these women actually had a family history of breast cancer, so they were at a high risk for breast cancer. And you know what they saw? In the women that got the testosterone implant, they did not have an increased risk of breast cancer. So testosterone was able to prevent the increased risk of breast cancer that the estrogen progestin therapy normally causes. And in the women that were not receiving the synthetic progestin, the hormone we know markedly increases the risk of breast cancer, they actually had a lower risk of breast cancer than women that were not receiving hormone therapy. So clearly, in a study out of Australia, testosterone was shown to be breast protective.
Some of the indications that you use testosterone sound similar to the indications that we try to help somebody with adrenal glands that are tired. Do you take care of the adrenals first and then work on the testosterone, or it doesn't matter, the order?
Actually, I do the reverse. Wow. I absolutely do the reverse, and that's something that I've learned over the past couple of years, and only with the testosterone implant. Mm-hmm. You're right. Indications: testosterone deficiency. You see a decreased libido and erectile dysfunction. That's what everybody thinks of as testosterone deficiency. But sleep disturbance, energy issues, fatigue, lack of endurance, depression, lack of motivation or self-confidence. These are the same things you see with adrenal fatigue. You know, the anxiety, the emotional lability. When you get a woman that has estrogen without testosterone, she has emotional lability. Small things can overwhelm her or upset her. There's memory loss. There's a decreased concentration. So these are real problems with testosterone deficiency that you can also see with adrenal fatigue. And I'll tell you what, I do treat people with adrenal fatigue, and I do use hydrocortisone in my practice. But what I have found is I use it a lot less frequently when I treat patients with testosterone first, because it clearly treats these symptoms.
Well, I've learned a lot, that's for sure. What do you see as the major problem with conventional hormone therapy?
I think the major problem with conventional hormone therapy, at least in women, is the fact that we equate it with estrogen therapy. And to me, women are much more symptomatic from testosterone deficiency. I feel we have an estrogen-dominant society, and treating these women with estrogen only puts them more out of balance.
What percentage of the women that you evaluate actually need testosterone?
The number of women I see that end up needing testosterone is probably 80 to 90%.
Wow.
But remember, that's why they're coming to see me.
Well, they're not feeling well.
Right. And like I said earlier, women at the age of 40 have half the testosterone as women at 20, and the women that are coming to see me are the symptomatic women, not just physical symptoms, but mental symptoms. So testosterone has been the most significant thing in my practice to help these women.
What about DHEA? DHEA converts into testosterone about 50% of the time in women. Do you ever start with DHEA and see if the woman will make her own testosterone?
No, and I know you can read these in little reports, but when you actually go look at the data to see what supports that, in a woman, the average dose of DHEA you want to treat her with is maybe 5 to 10 milligrams. Mm-hmm. In the literature, do you know how much DHEA it takes to actually increase testosterone minimally? A 50 to a 100 milligram dose.
Okay.
So you know what? DHEA does convert to testosterone in the adrenal gland where it's made. But when you actually look at the studies, you need a 50 to 100 milligram dose of DHEA to convert to testosterone in a woman. I have found greater clinical success using testosterone than I ever had with DHEA. I used to prescribe DHEA. I hardly ever do anymore.
What do you see in testosterone deficiency when these women come to see you?
Testosterone deficiency, actually the symptoms are very similar in men and women. One of the most common things that people think of when we talk about testosterone deficiency is a decreased libido or sex drive. It's also erectile dysfunction, not just in men, but also in women, their inability to have a climax or orgasm. A lot of people are unaware that testosterone deficiency causes sleep disturbances. The number one cause of insomnia in men and also sleep apnea is actually a testosterone deficiency. But it's a very important cause of sleep disturbance in women. And I have a lot of women who know when their pellets are wearing off when they start to wake up at night. So it's not just estrogen. I think even more important is testosterone deficiency. Testosterone is a huge hormone for energy, sense of well-being. So when you have deficient hormone levels of testosterone, you see that decreased energy, that overwhelming fatigue. People get tired. They can't function after 4 o'clock in the afternoon. Number one cause of depression in males over the age of 40, testosterone deficiency. But it's also a significant contributor to women in their 30s and 40s. And that's what I see. I see these women coming to my office. They're on antidepressants. They have low levels of testosterone. You treat them, and they have that sense of well-being back. They have that zest for life. Most of them, about 80%, are actually able to get off antidepressants. So it is a huge factor in mental status. We already talked a little bit about the anxiety and emotional lability that you see when you have testosterone deficiency. Testosterone is not just the physical strength hormone, it's that emotional strength hormone. The memory and concentration, huge. And we're not just talking about women and men in their 60s and 70s. I am talking about 40, 35-year-old females with memory loss. In fact, my youngest male patient is in his 20s, and his mom's a patient of mine. She's standing there at the checkout counter, and I've had this little thing on andropause right there, and she goes, could this be a factor in my son? 29 years old, and he had memory loss. He'd been to a couple neurological workups, had CAT scans, MRIs, and he gets told at 29 years of age, well, we won't be able to tell you for another 5 years or not if you have Alzheimer's disease. Mm-hmm. Now, how would you like to be a 29-year-old kid and hear that? So we look at his testosterone level, and he was low. He was within normal limits, but he was around 400, which is pretty low for a man of his age. And I couldn't tell him for sure that it was the cause of his memory loss, but we did treat him. We treated him with a pellet implant. 24 hours later, he felt better. His memory was back. So it is a huge thing for memory, but not just in men, for women also.
Have you treated any women with Alzheimer's and Parkinson's disease?
Oh, you bet I do. That is huge. Low testosterone is associated with Alzheimer's and Parkinson's disease. And not only I have treated, these people get unbelievable results only with the pellets, though. And that's what I cannot stress enough. The difference in the method of delivery with the testosterone pellet implant is huge. Their tremors improve, and even people with primary tremors, or what they call essential tremors, where there's no real cause for their hand tremor, you put the testosterone pellets in them, and their tremors go away. But their memory is better, their muscle mass, their coordination. If you look at a patient with Alzheimer's disease, okay, you get that the shuffling gait, you get the muscle weakness, all that. That's the same thing you see with testosterone deficiency. In fact, the first person I ever treated with a pellet implant was my dad who has Parkinson's disease. So I have seen a huge difference. Not only do their Parkinson's disease not progress, but they actually get a little bit better. So, yeah, it definitely helps both Alzheimer's and Parkinson's disease.
How long do these pellets last?
Well, in women, we use a smaller dose in women. Obviously, we have less testosterone than you guys do. Mm-hmm. And so in women, the average lasts about 4 months, and in men, they last about 5 months. So they have to be implanted 2 to 3 times a year.
And is it something that they would think that they're going to need for the rest of their life?
Well, right. For the most part, they do. Now, sometimes I have some women with postpartum depression or coming off the birth control pill. They might be in their early to mid-30s, and I do a testosterone pellet in them. They markedly improve, but this is the one age group where their ovaries could kick back on. Birth control pill actually suppresses the ovaries and suppresses your production of testosterone. So if you stop the birth control pill, your ovaries may kick back on. So that's the one age group where I would hope they could start making their own testosterone. But for the most part, if you're 50 years old, 60 years old, it's unlikely that all of a sudden your ovaries or testicles are going to start producing hormones.
So this is not a new form of treatment that somebody could say, yeah, but it's so new. In another 10 or 15 years, we're going to find out that this is causing another type of problem. This has been around long enough and used by lots of people.
Oh my gosh, it's been used since 1940. Even in the United States, there are special clinics that do hormone therapy with pellet implants. We have 22 and 30-year follow-up data on pellet implants. So this is not new therapy, and there's plenty of data that supports their use.
Okay, I'm sold.
The difference between the effect and efficacy of the pellet implants, and that's not just in the literature, it's what I've seen in my own practice, is absolutely unbelievable. And again, I don't use estrogen pellets hardly ever. It's the testosterone delivered by pellet implants that is so safe and so effective.
What are options for estrogen therapy?
Estrone and estradiol are stronger estrogens. Estriol, we already talked about, and a lot of times I will use a combination of estriol, the so-called weaker estrogen. It just has a different effect than the stronger estrogens, and estradiol. Estriol is used in Europe and Japan both orally and vaginally. There's a lot of data both on the absorption, efficacy, and safety of estriol. So I use estriol, and I use it mainly as a vaginal cream along with a little bit of estradiol. I think it's extremely safe. We know that it doesn't increase the risk of breast cancer. There are very few side effects. Estriol doesn't increase fluid retention or weight gain. So I really like to use estriol as part of my estrogen therapy. Now, a recent problem, at least in the United States, is the FDA came out and said there's no data on the efficacy or safety, and that simply isn't true. There's no data in the United States because no one has submitted it for FDA approval. There's extensive data in Europe and Japan on not only the safety of estriol, but how well it works.
What do you feel is the most effective and safest form of estrogen therapy?
Well, I like the vaginal delivery of hormone therapy. First of all, about 87% of women with complaints of hormone imbalance have GU symptoms, or gynecologic urinary symptoms. And what I mean by this is these women come in with vaginal dryness, urinary urgency, frequency, repeated urinary tract infections, and stress incontinence. And only about 50% of these women get relief of these GU symptoms with the topical patch, gel, or hormone pills. Whereas 95% of these women with these symptoms get relief with vaginal hormone therapy. So vaginal therapy of hormones is very effective for taking care of symptoms that the majority of women have. The other thing is we know that hormones applied vaginally are consistently absorbed and relieve symptoms of menopause. The other benefit of delivering hormones vaginally is that these hormones bypass the liver. When you take a hormone orally, like we spoke about earlier, it goes through the liver. So when you deliver hormones vaginally, it does not affect the clotting factors. It doesn't increase the risk of blood clots. Again, making it safe in women that have had a blood clot or a family history of blood clots. The other benefit is when you deliver hormones vaginally, including progesterone, you don't form the metabolites or breakdown products. When you don't have these metabolites, there are far fewer side effects. Vaginal delivery of hormone does not really affect your lipid profiles as sometimes other hormone delivery systems do. There's also no negative effect on blood pressure like there are with the synthetic progestin. In fact, vaginal estriol has been shown to lower the mean arterial blood pressure or lower blood pressure. We've covered this over and over, but the vaginal hormones do not increase the risk of breast cancer. And I like it because I can put multiple hormones into a single cream, which makes it very convenient for patients. There's a lot of data to support hormones delivered vaginally.
Women don't mind that mode of delivery?
Nope, and you're talking to women that have symptoms down there too, okay? But I think the reason they don't mind it is it's pretty convenient. When I give a testosterone pellet, they only have to use a vaginal cream about 3 days a week, so it's pretty convenient. But the thing is, I have it compounded into a small volume of cream, so they're not using that whole cc or gram of cream that, like they used to use in the old days that would be messy, that would be kind of not convenient to use. So we use a small volume of cream, which makes it a lot more convenient for the women to use. That takes care of the majority of their symptoms. We talked about the energy. We talked about sense of well-being. So these women are using the vaginal hormone cream a lot for the urinary and vaginal symptoms. This works particularly good in my women that are like 75 to 85 years of age. They come in, they get their testosterone pellet, and that's all they need and that's all they want. Their minds are functioning, they feel good, their aches and pains are gone, and they don't want to mess with anything else. So each patient's an individual, but for the most part, the younger women, I do the testosterone pellet along with the vaginal cream, but not everybody needs it. Some people need testosterone alone.
Are you seeing any improvement in osteoporosis profiles?
Oh my goodness, yes. I have seen in my personal practice an increase between 5 and 6% in bone density a year. And that's real bone density. It's not just how the bones look on DEXA scan, it's actual healthy bone density.
Mm-hmm. Well, tell us exactly what are these pellets and what do they look like and how do you put it in and why should everybody be be looking for this service?
Pellets are made up usually of either estradiol or testosterone. Now, over the past couple years, I have found that the women and men gain the majority of benefit from the testosterone pellet. And what they are, these hormones are compressed into very small cylinders. And they're slipped under the skin through a little device called a trocar. You make a tiny opening in the skin, either in the upper part of the buttocks or the lower quadrant, and they're just slipped under the skin into the subcutaneous tissue. A steri-strip or skin tape is then placed over the incision. There is an FDA-approved pellet in the United States that's FDA-approved for men, and they're tiny. They're half the size of a Tic Tac.
You don't have to have them compounded, or you do have to have them compounded?
Well, in the United States, the only dose that's manufactured is the 75 milligram testosterone pellet. So all other doses I have to have compounded. So a very common dose I use in women is a 100 milligram dose, which would be compounded. I usually use between 100 and 125 milligrams in women. So yes, for the most part, I'm having the pellets compounded to be the most effective and most bioidentical method to deliver hormones. They're actually more effective than oral or topical hormones.
You don't get the problem with the pellets of constantly having too much testosterone in the body?
Mm-mm. They release it at a very consistent rate over that 3 to 5 month period in women and that 4 to 6 month period in men. Only at the first 24 hours you might see a slight peak, but after that it's a very consistent release rate. In fact, one of the criticisms by people that don't do pellets, have never seen pellets, is that they don't want that consistent of a level. They want that diurnal variation. Well, we've done studies that show that the serum levels of testosterone vary throughout the day, extremely similar to ovarian or testicular production of testosterone. So that is not a valid criticism of pellets.
It must go according to the blood flow. As the blood flow increases, it must carry off more testosterone from the pellet, which
Exactly.
mimics the way the body works.
And you see that peak in the morning, just like you do with testicular production, and I think that's from a decreased metabolism overnight. But we did it when we did the studies. The people would exercise. We'd look immediately after exercise. We'd look 2 hours after exercise. And you're right, blood flow was a factor in the release, just like it would be expected from the testicles or ovaries.
Well, how does that work with increased flow when the person's sleeping?
2 different reasons you'll see different levels of hormones in the bloodstream throughout the 24-hour period.
Mm-hmm.
And I think one of them is the rate of metabolism, and one of them is the rate of release. Okay? So when you're sleeping and you lower your metabolic rate or lower the rate you're metabolizing the hormones, I think you wake up and you have a slightly higher level in the bloodstream.
I see. Is having the pellets placed a difficult process?
Oh my gosh. Well, I'm a surgeon, but even for me, it's a pretty simple procedure. It takes about 30 seconds in a woman, and it takes about 2 minutes in a man. And so it's a very minor procedure. You numb up the skin with a little bit of local anesthetic, similar to what the dentist office uses. You just make a tiny opening in the skin and put the pellets under and put a steri-strip on it or skin tape. So it's a very simple procedure.
You train other doctors how to do this?
Yes, I do.
Okay.
Coming over?
I'll be over. How about for men? You treat men with this also?
Oh, yeah. Probably about 10% of my patients are men. 10 to 20% of patients are men. Yeah, they just do phenomenal in the pellet implant. Now, in men, one of the things we do is we watch that PSA because we know that testosterone does not cause prostate cancer, but if a man has an undiagnosed prostate cancer, it could possibly stimulate it. So what we do is sometimes when I see a man, if their PSA is a little bit elevated, I will put them on a different form of testosterone delivery, either the sublingual lozenge or a topical gel or maybe even a patch for about 2 to 3 months and recheck that PSA.
Mm-hmm.
If it stays stable, they get the pellets. But I can't tell you the difference in efficacy, especially when you're looking at memory, concentration, depression, insomnia, or Alzheimer's or Parkinson's disease. The pellets are so much more effective. The other group of patients are the multiple sclerosis patients. And again, I've tried to get one group that's researching multiple sclerosis interested in the pellets, but they're already probably doing research on the androgen gel. So they weren't interested in looking at the pellets, even though they are so much more effective. But those MS patients, not only do their brains function better, but their muscles, their nerves, and their incontinence gets better. So it has been a huge benefit to MS patients. And we know testosterone works in MS patients, but this is the most effective delivery method.
Do these pellets dissolve, or do you have to take them out when you put the next one in?
Great question. And I got asked that by patients and didn't really understand why they were asking it, but some patients were familiar with the old Norplant implant, which they use for birth control.
Right.
And these pellets are totally testosterone or estradiol, so they completely dissolve. They do not have to be removed.
And you rotate the areas of application, I guess.
Very good. Yes, we do. What it is most people like them on their upper, the upper buttocks. We say the hip, but it's not where you lay and it's not where you sit.
Right.
And one time I'll do the right side, the next time I'll go and do the left side. And sometimes we'll put them on the right lower quadrant, but I go back and forth, usually through the same incision multiple times, if I can find it. The incision is so tiny, sometimes I can't even find it.
Right. What would you like the listeners to remember from this presentation?
Probably the most important word I want them to take away is balance. Hormones in balance maintain health and prevent disease. And important to me is that they understand that hormones in balance do not increase the risk of breast cancer. Bioidentical hormones, not given orally, do not increase the risk of blood clots or affect the liver. They are cardiac, heart, and brain protective. It's the synthetic hormones that have negative effects both on the heart and the brain. I think you have to look at each individual and individualize hormone therapy. I think they got to be careful when they read newspaper articles because a lot of times they sensationalize things and group all hormones together. And one thing that it took me years to really understand is that pharmaceutical companies are extremely powerful forces, not only in education and medicine, politics and the economy, but now in research. Almost every medical conference you go to is sponsored by the pharmaceutical companies. So much of the research being done at the major universities is sponsored by the pharmaceutical companies, and so much of the money and honorariums given to the physicians coming out making statements on hormones is from the pharmaceutical companies. So I think I didn't understand how powerful they were.
Okay, it's a little awesome understanding that our health, which we're entrusting to our physician, who is definitely well-meaning and wanting to help us, is really being educated with statistics and with research that's one-sided for the sale of the medicines that he's wanted to prescribe. Mm-hmm. Well, Dr. Glaser, you really have taught us a lot, and I think that there's going to be a lot of people coming to the Millennium Wellness Center.
Oh, no!
and probably a lot of doctors, because the case that you make isn't a theoretical case. It's based in research, and it's based in your practice, and your results are, you're a well-known speaker around for physicians, and now patients are hearing it, they're being empowered, and they're going to start asking for this type of treatment, and I'm sure that people are going to be coming to you for advice. So I appreciate your sharing all that information with us today, okay, and looking forward to seeing your progress in this field in the future.
Thank you very much.
We have with us Stephen Joyal, Vice President of Scientific Affairs at Life Extension Foundation, to tell us of a few very special products that Life Extension has that can help us with balancing our hormones. Dr. Joyal.
Thank you, Dr. Yaffe. It's a pleasure to speak with you today. Life Extension as an organization has been in existence for over 28 years. We have as our mission to extend and enhance human life. And we're very interested in hormonal restoration as well as achieving hormone balance. And to that point, we have several products that we feel very proud about and that have been really designed in a sophisticated way to help balance not only the aging woman's hormonal balance, but also the aging male. So the first product that I'd like to talk a little bit about is our breast health formula. As you know, Dr. Yaffa, breast health is of prime importance to the vast majority of aging women, and we've designed this product in a very sophisticated way to really help modulate and achieve hormone balance. One of the important things to remember when we talk about estrogens is that there are different types of estrogen metabolites that exist in the body. And there's a good amount of literature looking at, and I'll call it a so-called good estrogen metabolite called 2-hydroxyestrone, as well as a so-called bad estrogen metabolite called 16-alpha-hydroxyestrone. And what a number of studies have shown is that achieving an optimal ratio of 2-hydroxyestrone to 16-alpha-hydroxyestrone can be very beneficial. In fact, that ratio has been used as a surrogate biomarker in a variety of conditions, including hormone-responsive cancers such as cancers of the breast. So back to our formula. We've really designed this formula to incorporate a variety of ingredients to really help achieve an optimal or ideal balance of 2-hydroxyestrone to 16-alpha-hydroxyestrone. One important constituent of the formula includes cruciferous vegetable extracts. We have a variety of them in the product, including broccoli as well as watercress. Interestingly, watercress is a cruciferous vegetable. So what these cruciferous vegetables do, and some of their constituents, which I'll talk about in a moment, they have been shown in a variety of studies, including clinical studies, to help balance or normalize the ratio of 2-hydroxyestrone to 16-alpha-hydroxyestrone. Two important components of cruciferous vegetables include indole-3-carbinol, also known as I3C, as well as something called DIM, which is 3,3-bis-indole-methane. Both of these are important and have been shown in clinical studies, in fact, to help optimize the ratio of 2-hydroxy to 16-alpha-hydroxyestrone. Also included in the formulation, our breast health formula, includes lignans from the Norway spruce, something called HMR lignin. Now, this is a very interesting ingredient and has been also shown in a variety of studies to help support healthy estrogen metabolism. Let me also add as well that cruciferous vegetable extracts as well as indole-3-carbinol and DIM have all been shown to favorably modulate something called phase 1 detoxification enzymes in the liver, also which can help really modulate and remove a lot of the phytoestrogens and xenoestrogens that are really plentiful in an environment. So that's a little synopsis on our breast health formula. I had mentioned earlier in our discussion the fact that we have a great product looking to help aging men achieve hormone balance. One of the big concerns of aging men is prostate health. And what we know, and this is well known from the scientific and medical literature, is that there are different hormones such as DHT, also known as dihydrotestosterone, which is made from testosterone and actually converted from testosterone by an enzyme called 5-alpha reductase. In fact, DHT, dihydrotestosterone, has been shown in a variety of studies to be a leading cause of prostate growth and enlargement in aging men. So, too, there has been recent literature, and it's very interesting because this is pretty cutting-edge stuff, that estrogen, particularly estradiol, looks to be a very important factor contributing to growth of the prostate in aging men. And it is likely, although not known for certain, but it is likely that the impact of both dihydrotestosterone as well as estradiol really seems to fuel growth, or I should say hypertrophy, of the prostate gland in aging men. So our product focus, which is our ultra-natural prostate with 5-loxane as well as lignin, is really designed to target a variety of aspects of an aging man's hormone physiology. Now, one product, which will, I'm sure, be known to many people, is saw palmetto. We have a supercritical carbon dioxide extract. It is standardized to 85 to 95% free fatty acids and sterols. This we found, based upon our review of the literature, including clinical studies, to be critically important to really see efficacy with saw palmetto. We also have something called cernitin, C-E-R-N-I-T-I-N. This is a flower pollen extract, and this has been shown in several different studies to help relax smooth muscle tone of the urethra, and it may also help counteract some of the impact of DHT, dihydrotestosterone. It also appears to have an anti-inflammatory effect, and it's been thought of in the literature that, in fact, one of the reasons why saw palmetto, as well as a variety of other ingredients, including cernitin, have demonstrated efficacy for helping to support healthy aging of the prostate may in fact be to these anti-inflammatory effects. I want to talk a little bit about something called 5-loxane. Now, 5-loxane is a specific ingredient derived from boswellia, and our particular source of boswellia is standardized to acetyl-L-keto-beta-boswellic acid. This is also very important. We know that inflammation, as well as certain inflammatory pathways, including a critical enzyme called 5-lipoxygenase, is involved in some of the activity responsible for growth and enlargement of the aging prostate. So this particular ingredient, 5-loxane, is in our formula to help control for some of those adverse effects. We have a variety of other ingredients in this. Pygium, that actually is something that should be familiar to many people. Our pygium, our raw material that we use in our formula, is standardized to a little over 11% of sterols as beta-cytosterol. And what we know, based upon the literature, is that beta-cytosterol is really the important factor in pygium responsible for its beneficial health effects. And there have been a variety of studies showing that pygium standardized to beta-cytosterol really helps support healthy prostaglandin function. Now, prostaglandins is something that our organization has been very interested in for a number of years. In fact, we've written a great deal about the importance of balancing prostaglandin synthesis in the body. Some people may not be aware that there are a variety of prostaglandins, including prostaglandin E2, we talk about thromboxane A4, and also leukotriene B4. These are all important mediators of inflammation that our organization has written about in the past, and that really aging men need to be aware of in order to achieve healthy prostate function as they age. Talk about a couple other components in this. Similar to our breast health formula, in our ultra-natural prostate formula, we also have a lignin source, also the Norway spruce source. And this is a very specific source, and the reason that this is in the product is for a variety of reasons. The most important is that there have been several studies showing that this particular source of lignin tends to balance some of the adverse effects that we see in aging men from both excess estradiol as well as excess DHT, dihydrotestosterone. So in a synopsis of both products, as you can tell, these are sophisticated products. We use a variety of ingredients that are in these products really designed for synergy, looking to help target and assess all of the various factors responsible for hormone balance, both in aging men as well as aging women.
That's fabulous. I really appreciate it. Life Extension has such a wonderful name. It brings such great research. It puts together such great combinations that for the benefit of so many of us that I'm sure that the people listening will appreciate being able to avail themselves to those two great products. Thanks very much, Dr. Joyelle, for your time.
Thank you. My privilege.
I'd like to thank Dr. Rebecca Glaser for her interview on hormone balance, bioidentical hormones, and testosterone in particular. And I would like to thank Dr. Stephen Joyelle from the Life Extension Foundation for explaining two of their premier products. The information given during this audio interview, and which is on this website that you are viewing during the BHRT World Summit, is not intended to replace a one-on-one relationship with a qualified healthcare professional and is not intended as medical advice. It is intended as a sharing of knowledge and information from the research and experience of the practitioners in the field. I encourage you to partner with your own qualified healthcare provider to make the appropriate decisions for your individual best health. Thanks for joining us.